I think I know pretty much everybody here. I'm Steph. I'm one of the PGY4s. My supervisor was George Mastoris, and today we're going to be talking about vitamins in the ED. So the objectives for today are to discuss some potential harms from vitamin and supplement use, discuss some potential uses for vitamins and supplements in the ED, and then we'll discuss the recent suggestion of vitamins and steroids as a treatment for sepsis. So why are we even talking about this? Well, the global vitamin and supplement industry is expected to be worth $278 billion by 2024. Various celebrities have posted photos of themselves on Instagram and Snapchat getting IV vitamin therapy. Professional athletes use them. There's all sorts of blogs for endurance athletes in particular that tout their supposed benefits. And even celebrities like Gwyneth Paltrow have gotten in on the game. She recently released her own line of supplements with names like Why Am I So Effing Tired, which claims to boost energy, and High School Genes, which claims to help with weight loss. IV therapy lounges have popped up in Toronto and Vancouver, and there are a number of naturopaths in Ottawa that are offering the treatment as well. And IV therapy is actually one of the most advertised treatments offered by naturopaths in Canada. And they even give you fun menus of things to choose from, like the hot flash, the fertility, or the hangover cure. So when you take a look online, there are all sorts of claims for what vitamins, minerals, and supplements can do, including treating Parkinson's, macular degeneration, fibromyalgia, depression, adrenal fatigue, whatever that is, and the catch-all detoxification. And unfortunately, it's also not uncommon for us to encounter cancer patients who've decided to try quote-unquote natural treatments rather than conventional chemotherapy and radiation. And if you type vitamin C cures cancer into YouTube, for example, you'll find thousands of people claiming just this. So let's start out by discussing some potential harms that vitamins and supplements can cause for our patients. I'm not going to be able to talk about everything. Instead, I'll just highlight a select few. So a study by Geller et al. Published in 2015 in the New England Journal used surveillance data from 63 U.S. emergency departments between 2004 and 2013 to look at the characteristics of ED visits related to vitamin and supplement use. And they found 3,667 cases in their sample, which they then extrapolated to suggest that there are 23,000 visits to the ED for adverse events related to supplement use and over 2,000 admissions every year. And the mean age for these visits was actually 32. Once they excluded children with an unsupervised ingestion, 66% of visits were related to herbal or complementary nutritional products, which are botanicals or amino acids, and 32% were for micronutrients, which were vitamins or minerals. And the most common reasons for taking the supplements were for increased energy or weight loss, and the most common side effects from these were palpitations, chest pain, or tachycardia. So we're going to start with a case. A 23-year-old male is brought into the ED by his mother. He has altered mental status, generalized weakness, and vomiting. You're unable to get a history from the patient, but his mom tells you that he regularly uses MDMA. His vitals are temperature 38.1, heart rate 99, BP 104 on 62, SATs 99% on room air. And on exam, the patient appears acutely ill, diaphoretic, and jaundiced. There are bilateral basilar crackles, he's confused and agitated, and there is mild right-sided weakness. And the rest of his exam is unremarkable. So you get some lab work. His sugar is slightly high and he's alkalotic. White blood cells are 21 with a hemoglobin of 109, and he's thrombocytopenic at 21. He also has schistocytes. Lights are relatively unremarkable. Urea and creatinine are both elevated though, slightly elevated AST and a very high bili. INR is also elevated. Tox screen, though, is unremarkable. His urine shows 2+ protein and 4+ blood, and the comment on the micro just says that there are too many red blood cells to comment on anything else. And for what it's worth, his urine drug screen is also negative. At this point, his BP drops to 81 on 45, which then responds to a fluid bolus. So as the patient is being taken up to ICU, your medical student comes to you because he's been talking to the patient's mother, who says that her son has been taking a lot of niacin in order to beat a drug test for his new job. The patient took 22 grams over the course of about 2 days. So in the ICU, he had a seizure and was intubated for hypoxia. His hemoglobin and platelets continued to fall, and he was transfused red blood cells, FFP, and platelets. He was started on dialysis for oliguric renal failure. He was hyperglycemic with sugars in the 11 to 14 range, and then an EEG done at the bedside was consistent with metabolic encephalopathy. His liver enzymes peaked with AST and ALT of about 1,000, INR peaked at 2.2, and his CK was also elevated. But by day 5, he had stabilized, his kidney function had recovered, he was extubated and was transferred to medicine, and then he was discharged home on day 10. So let's talk briefly about niacin toxicity. Niacin is generally used to help lower cholesterol levels, but niacin is one method that the internet recommends trying in order to pass a urine drug test. And people are generally under the impression that more is more. So there are a few cases in the literature that discuss niacin toxicity related to trying to pass a drug test. For what it's worth, there is no evidence that niacin is actually capable of flushing drug metabolites out of your body, but the method does persist online. And there are also cases of niacin toxicity from some of the sustained release formulas. Niacin's side effects include flushing of the skin and pruritus, and these tend to occur more with the immediate release formulas. Sustained release formulas have been created to combat this, and these can commonly cause GI upset. Elevated liver enzymes could be seen with doses of 1 gram per day, and both the sustained and immediate release formulas can give you hyperglycemia through the promotion of insulin resistance, it's thought. Niacin toxicity generally occurs once you reach doses of 2 to 3 grams per day, and patients typically present with fatigue, anorexia, nausea, vomiting, and jaundice. Hepatic dysfunction can be present with elevated bili, ammonia, INR, PTT, and liver enzymes. Most of the time, the hepatic dysfunction recovers once patients stop taking niacin, but it can progress to fulminant hepatic failure. And the case that we just went through is the first known instance of TTP and DIC related to niacin toxicity, and it also appears to be the highest dose taken, at least from what's reported in the literature. The key with most harms that occur from vitamins and other supplements is that people take them in massive doses, generally under the assumption that they're natural products and therefore they couldn't possibly harm you. But as you can see, the recommended daily intake for niacin is 35 milligrams per day. Most formulas actually come in 100 milligrams up to 500 milligram tabs. So it becomes really easy for patients to be taking more than the safe upper limit. This is just a brief rundown of some side effects from other vitamins. Vitamin A toxicity can lead to hair loss and skin changes. There's an increased fracture risk, and you can get hypercalcemia and hepatotoxicity, and it can actually also cause idiopathic intracranial hypertension. Signs of an acute overdose include headache, papilledema, visual changes, seizures, altered LOC, nausea and vomiting, abdopain, liver damage, and desquamation. And symptoms generally begin within a few hours of an acute ingestion. Vitamin C toxicity is possibly associated with the formation of oxalate kidney stones, although the literature on this is pretty mixed. Most cases have been associated with very high-dose IV vitamin C or in patients with chronic renal failure. But side effects from vitamin C can also include a localized piloesophagitis from prolonged mucosal contact with ascorbic acid and an osmotic diarrhea. Patients with vitamin D toxicity generally present with signs and symptoms consistent with hypercalcemia, so weakness, fatigue, altered LOC, headache, dizziness, bone pain, nausea, vomiting, and abdo cramps. But with increasing calcium concentration, you can also get polyuria and polydipsia. And then in severe hypercalcemia, patients can present with ataxia, confusion, psychosis, seizures, coma, renal failure, ECG changes such as PR prolongation, widened QRS, QT shortening, and flat T waves. You can also get dysrhythmias. And there have also been case reports of anemia related to vitamin D toxicity, but the pathophysiology isn't really known. So case number 2, a 35-year-old female is brought by EMS after she called 911 because of stuttering speech and diaphoresis. Her vitals with EMS are temp 37, heart rate 102, BP 169 on 100. She's diaphoretic and she appears anxious. She has stuttering speech that isn't aphasic. Her ECG shows tachycardia at 120. And her neurological exam is remarkable for spontaneous ankle clonus, bilateral ocular clonus, hyperreflexia, tremor, and inducible jaw clonus, which is what's causing her stuttering speech. So she appears to have serotonin syndrome, but she denies any illicit drug use, and her urine drug screen that medicine orders ends up being negative. She mentions that she's been on citalopram up until about a month ago when she developed flushing, a tremor, and diaphoresis. So she was weaned off antidepressants and had been off everything for about 2 weeks, and then was just started on sertraline about a week ago. So after further questioning, she mentions that she started taking Garcinia cambogia for weight loss about 2 months ago after seeing an episode of Dr. Oz and doing some research online. She hadn't told her doctor about the weight loss supplement when she was previously diagnosed with serotonin syndrome. So you treat her with IV benzos, her symptoms improve, but medicine admits her for monitoring. And she has some hallucinations overnight, gets more benzos, but stops taking the Garcinia cambogia and sertraline, recovers, and is discharged home. So Garcinia cambogia is a dietary supplement that became popular for weight loss and became more widely known after Dr. Oz was plugging it on his show. The claims from manufacturers are that it boosts weight loss by slowing the body's ability to store fat and that it helps suppress appetite, but it's actually a fruit found in Southeast Asia and India, and the active ingredient is thought to be hydroxycitric acid, or HCA. A couple of systematic reviews and meta-analyses suggest that there is little, if any, sustained weight loss from Garcinia cambogia, but there is also some limited evidence that suggests that HCA can inhibit serotonin uptake. So in addition to the case study I just presented, there's been a case series published of people with stable bipolar disorder who developed mania after taking Garcinia cambogia, and another case of somebody developing mania after taking the supplement hydroxycut, which can also contain HCA. Obviously, there are too many weight loss supplements to mention here, so I'll just go over a couple of common ones. Green tea extract has been associated with hepatotoxicity and liver failure, and there are a number of cases of people requiring liver transplants associated with its use. Mawang is a natural source of ephedrine, so unsurprisingly it acts as a sympathomimetic and can cause psychosis. It's been banned in the US and Canada, but is extremely easy to buy online, so you may run into it. Glucomannan expands on contact with water, which is what causes you to feel full and therefore suppresses the appetite. But there have also been cases of GI obstruction, which has led to the tablet form being banned, but it is still available as a capsule. And then Orlistat is available as both a prescription and non-prescription formula for weight loss. It inhibits gastric and pancreatic lipase and ends up increasing fecal fat excretion. So its side effects are mostly local GI side effects, but there have been rare cases of hepatotoxicity linked to it as well. And then it's also important to know that there are multiple weight loss supplements that have combination ingredients, an example being hydroxycut, which has multiple different formulas depending on which version you get and also what country it's marketed in. And I just wanted to quickly make note of another supplement. It's called amygdalin laetrile or bitter apricot kernel, but it's also marketed as vitamin B17 despite it not actually being classified as a vitamin. It's found in apricot seeds and is supposedly a treatment for cancer in the alternative health world, although it's never actually been proven to be effective. But what has been shown is that it can lead to cyanide toxicity, and there have been fatalities that have been described from its use. It's not legal in Canada, but like most things, it's available online, and last year Health Canada actually had to put out a warning because there was a Canadian online supplier that started selling it. Okay, so the benefits of vitamin supplementation are well known for deficiencies like thiamine for Wernicke's encephalopathy, vitamin C to treat scurvy, vitamin A for night blindness, and niacin to treat pellagra. So I'm not going to be talking about these. If you do want a quick rundown, there's a 20-minute podcast on MRAP from September 2016, which gives a good overview. I'm also not going to be talking about vitamin K for the reversal of warfarin or magnesium for asthma, etc. Instead, I'd like to talk about some less well-known potential benefits of vitamins and supplements that might have some use in the ED. So case number 3, you pick up a chart in urgent care for a 65-year-old man with foot pain. He has a history of type 2 diabetes, hypertension, and high cholesterol, as well as peripheral neuropathy. His medications include pregabalin and oxycodone. And when you see him, he tells you that his peripheral neuropathy has been really bad the last couple of weeks. He tried to see his regular doctor, but he couldn't. He's tried tricyclics and gabapentin previously. His history, physical, and investigations don't give an alternative explanation for his worsening foot pain. And he just asked if there's anything else he could possibly try to help with his pain. which, I mean, I think we've all had some version of this story. Someone presents to the ED with an acute flare of their chronic pain, and is there anything else that we might be able to suggest? So there have actually been a few studies published that propose a link between vitamin D deficiency in diabetics and peripheral neuropathy, or just symptoms of paresthesias and numbness. And there have also been some small studies that have shown improvement in symptoms, including pain, for diabetic patients with peripheral neuropathy after the treatment with vitamin D. So this study was published in BMJ Open Diabetes Research and Care last year. It was a prospective open-label study conducted in Pakistan. 143 patients were given 600,000 international units of vitamin D3 IM at their first visit. They were then followed for 20 weeks, and the authors found that 40% of their patients had vitamin D deficiency at the beginning of their study. Vitamin D levels increased to a statistically significant degree, and they found that symptoms had significantly improved by the 10-week mark of the study. And interestingly, you didn't have to have vitamin D deficiency in order to experience improvement. So obviously, this was not a placebo-controlled study. There were a small number of patients, but I think it's still interesting. Painful diabetic neuropathy, though, isn't the only painful condition that vitamin D might be correlated with. A health survey of adults over 65 in England in 2012 found that moderate and severe chronic pain was associated with low vitamin D levels independent of other risk factors. Other studies have found low vitamin D levels to be associated with chronic pain in women but not men. Also, Aboriginal Australian patients with myalgias and women with low back pain. And there have also been other small case series and studies that suggest that vitamin D supplementation may help reduce musculoskeletal pain. There was also a small RCT that showed a single dose of 300,000 international units of vitamin D prior to menstruation may help women with dysmenorrhea for up to 2 months. And the authors hypothesized that vitamin D may affect the expression of genes in the prostaglandin pathway, leading to this effect. In 2015, there was a Cochrane review published looking at whether vitamin D supplementation is a useful treatment for various chronic pain conditions. And given that this is a Cochrane review, they only looked at studies that made a comparison to placebo or medications used to treat chronic pain. They found a total of 10 studies and 811 patients. And vitamin D in the studies was used to treat conditions like rheumatoid arthritis, knee osteoarthritis, PMR, nonspecific diffuse musculoskeletal pain, and fibromyalgia. The studies used various types of vitamin D doses and routes, though, and there was no convincing beneficial effect of vitamin D on chronic pain. But the quality of the studies were poor and were very heterogeneous, so Cochrane basically concluded that more research is needed. So does vitamin D work for chronically painful conditions? I think at this point all we can say is maybe. But there are other possible uses for vitamin D supplementation, including possibly preventing ARDS in vitamin D deficient patients who are otherwise at risk. So this is a study that's currently recruiting at Massachusetts General Hospital in Boston. And vitamin D may also reduce the risk of asthma exacerbations requiring systemic corticosteroids or exacerbations leading to an ED visit or hospitalization. And if you search vitamin D on clinicaltrials.gov, there are over 600 open trials currently. And when you restrict it to just looking at the effect of vitamin D supplementation, there are still over 100 studies looking at things such as cognitive function in older adults, pneumonia in children, various cancers, and MS. Currently, no other vitamins and dietary supplements seem to have as much attention, although there are a wide variety of studies that are currently in progress. Okay. So this next topic I expect to be controversial, which is why I saved it for last. We're going to talk about the combination of vitamin C, thiamine, and steroids as an adjunctive treatment for sepsis, the so-called metabolic resuscitation or the Merrick protocol. So case number 4. A patch comes in. There's a 48-year-old female being brought in by EMS. She's about 4 minutes out. Her temp is 39.2, heart rate 120, BP 78 on 40, resp rate 30. SATs are 75% initially on room air, but now she's being bagged and has SATs of about 94%. Her GCS is 6, and the paramedics say that they were unable to get a line. So you set up your resus bay, and when she arrives, the nurses get lines, she's given fluid, antibiotics, she's intubated, but her pressure is still low, so you start her on Levophed, you call the ICU, and she appears to be in septic shock. She's also started on vasopressin, but the ICU comes, they take her upstairs, and then you hear a little while later that she's already maxed out on 4 pressors and they're starting SLED. So your very keen resident who follows a lot of foam blogs and is active on Twitter asks you whether you think that there would be a role for vitamin C, thiamine, and steroids. Okay, so for anyone that missed all the fuss, Paul Merrick, who's a well-known critical care physician in Virginia, published a paper at the end of 2016 in Chest that outlined his use of IV vitamin C, thiamine, and steroids to treat severe sepsis and septic shock. And there wasn't much publicity about it until Eastern Virginia Medical School and Centera Healthcare, where Merrick works, released a joint press release with some really fancy videos that had really dramatic background music. And the story got published on NPR on March 23rd. And it then got picked up by other media outlets like local news affiliates, particularly in Virginia, but also alternative health blogs. And it even got picked up by The Independent in the UK. And I'm sure that no one here is surprised that it was also all over foam and social media. Comments are still going strong on the various blog posts and podcasts that have been dedicated to this topic. There was one just a few days ago, so I had to add extra things to my grand rounds. And needless to say, many people have been extremely skeptical. And also, I'm sure it's surprising to no one, but the media and the general public seem to have misinterpreted the study. So obviously, antibiotics in particular are still important for sepsis, and Merrick is not claiming that it's not. But within a few days, families were apparently requesting vitamin C to be given to their septic family members. Okay, so let's discuss the actual study. The story basically goes like this. There was a 48-year-old woman with severe sepsis who was maxed out on pressors. She was in multi-organ failure, and Merrick decided to try a combination of vitamin C and hydrocortisone for reasons that I'll get into later. He then left for the night, and the ICU nurses were amazed that she turned around within hours, and she was actually able to leave the ICU 2 days later. So he tried the combination on 2 more patients and saw the same miraculous recovery. So he started doing it for everyone, and he also added in thiamine at that point. And then he published what he found. So this is a retrospective, single-center, propensity-matched before and after study consisting of 47 patients each with severe sepsis or septic shock. They used consecutive patients in both the before and after groups, but the first 3 pivotal cases, as Merrick refers to them, were not included in the study. So the intervention group received vitamin C IV, 1.5 grams Q6 for 4 days or until ICU discharge, hydrocortisone 50 milligrams IV Q6 for 7 days or until ICU discharge, and then a 3-day taper, and thiamine 200 milligrams IV Q12 for 4 days or until ICU discharge. The control group received hydrocortisone 50 milligrams IV Q6 per the current guidelines, but at the discretion of the attending. Both groups received broad-spectrum antibiotics that were then de-escalated as appropriate. And it's important to note that the medical ICU where Merrick works, they also practice a fluid-restrictive resuscitation strategy. So no 2-liter boluses up front. They don't do the 30 cc per kilo bolus that the U.S. federal government mandates. Levofed is started early, often through peripheral IVs. Ventilated patients get a lung protective ventilator strategy. Patients receive enteral nutrition once they're clinically stable. They allow permissive hyperglycemia, and routine stress ulcer prophylaxis isn't given. So now on to the results. There were no differences in the baseline characteristics between the 2 groups. They were well matched on comorbidities, primary diagnosis, initial SOFA and Apache scores, and predicted mortality. The primary outcome for the study was in-hospital mortality. They found a mortality rate of 40.4% in their control group from before the introduction of vitamin C and thiamine, compared to 8.5% after the introduction. So this is an absolute difference of 31.9%, which gives a number needed to treat of 3.1 rounded up to 4. Their secondary outcomes included duration of vasopressors, where there was a difference of 54.9 hours to 18.3 hours. Percentage requiring renal replacement therapy went from 37% to 10%, And the SOFA scores over 72 hours changed 0.9 points in the control group versus 4.8 points in the treatment group. So if you take these results at face value, I mean, they're very impressive. The authors conclude that the early use of IV vitamin C, thiamine, and corticosteroids may be effective in preventing progression of organ dysfunction and reducing mortality in severe sepsis and septic shock. And the paper just concludes that these are preliminary findings. However, the hospital where Merrick works has actually made this standard of care because it was so practice-changing for them. They've treated over 250 patients now with this, and they claim to have no deaths from progressive organ failure secondary to sepsis. They initiate these interventions in the ED, and the protocol is also being adopted by other institutions across their hospital system. So they no longer feel that they have clinical equipoise, and they're not going to be doing an RCT for this. There are some physicians around the world who have also been impressed by the results and feel that there are a few downsides, so they've tried it as well, often sending Merrick emails detailing remarkable turnarounds for their patients. So Merrick has said that there are now over 50 centers following his protocol, and at least 400 patients have been treated with it. But obviously, there are a number of criticisms of this study, and as I mentioned earlier, people are pretty skeptical. So it is a retrospective study. The patients weren't randomized. No one was blinded. There were a small number of patients, and this was done at a single center. Obviously, we know that association doesn't mean causation, and there could be a lot of co-founders. So, for example, there could be improved nursing care that led to this change. Also, a number of people have brought up the high mortality rates in the control group. So, as I mentioned, it was 40.4% prior to the introduction of vitamin C and thiamine. But the mortality rate for sepsis is closer to 25% in most studies. So, is there something different about these patients, or is there something different about the care that was provided pre-intervention? These are valid questions, and this basically speaks to whether there's any external validity for the study. And then there's also the fact that it does seem a little bit too good to be true. There have been a multitude of treatments tried over the years to prevent sepsis or to treat sepsis, and they were all supposed miracle cures as well, like activated protein C, methylene blue, calcitriol, hemofiltration, et cetera, I could go on. So is this one any different? Okay, so for anyone that's curious as to why Merrick decided to try this combination in the first place, like I was, I'm going to go over some of the other evidence for vitamin C, thiamine, and steroids in combination. There's been a lot of discussion of steroids and sepsis both in our recent journal clubs and in Julie's grand rounds from last year, so I'm not going to be discussing steroids in as much detail. But let's get to the supporting evidence. So, in sepsis, vitamin C levels fall. Low vitamin C levels correlate with increased multi-organ failure and death. And in sepsis, vitamin C levels can only be corrected with large doses of at least 3 grams per day of IV vitamin C. In a prospective RCT from Tanaka et al., they found that giving IV vitamin C to severe burn patients reduced the resuscitation fluid volumes that were required. And in another prospective RCT, Nathans et al. Found that the combination of vitamin C and E reduced the risk of multi-organ failure in 6 surgical patients. In a third prospective RCT, Fowler et al. Randomized patients with severe sepsis to placebo, low-dose vitamin C of 12.5 milligrams per kilogram Q6, or high-dose vitamin C of 50 milligrams per kilogram Q6. And the primary outcome was safety and tolerability, and they had no adverse events that were recorded. But vitamin C did produce a dose-dependent reduction in SOFA scores over time, and the more dramatic changes were in the high-dose vitamin C group. We know that vitamin C is required for the synthesis of catecholamines like norepinephrine and vasopressin. So there have been many authors that have speculated that it could help wean vasopressors faster. Zabit et al. Showed in a small RCT of surgical ICU patients dependent on pressors that vitamin C reduced dose and duration of pressors, and also showed a decreased mortality from 64% to 14%, which was much more pronounced than the reduction that Merrick found even. Thiamine levels are also low in sepsis, and there is an increased mortality associated with thiamine deficiency in sepsis. Thymine is an important cofactor for pyruvate dehydrogenase and other enzymes that are important for the Krebs cycle. And don't worry, that is the last thing I'm going to say about the Krebs cycle. But it's not surprising then that thymine deficiency is associated with lactic acidosis. There was a small prospective double-blind placebo-controlled RCT that found that thymine administration reduced lactate levels and mortality in the subgroup of septic patients that were thymine deficient, but it didn't have any effect on the rest of their sample. So then, how did the steroids fit in? We keep studying corticosteroids in sepsis. We keep getting mixed results, and the adrenal trial is ongoing and hopefully will help answer some of the questions. But steroids in sepsis intuitively make sense. Sepsis involves a huge inflammatory response. Cortisol levels are low, we know this. So in theory, we should be giving glucocorticoids. But vitamin C is necessary for the synthesis of cortisol, and vitamin C may restore sensitivity to glucocorticoids. Two recent RCTs done in 2016 showed that a dose of vitamin C given preoperatively prevented the etomidate-induced adrenal suppression that you can often see. And so then why the combination of all three? Basically, thymine may prevent calcium oxalate formation, which, if you recall from part 1, is a potential side effect of vitamin C, although in much higher doses than given in any of these studies. And Merrick proposes that the combination works on multiple pathways and they overlap and work synergistically to provide their effect, such as reducing endothelial dysfunction, which is overwhelming in sepsis. So what's the consensus? Is this promising or is this complete nonsense? Should we be waiting for an RCT or just more observational data? I think it's important to think about what you would say to a patient's family member, though, if they requested it, since this has been spread pretty widely in mainstream media. NPR has followed up their original story with another one about why vitamin C in sepsis needs more study, but the news cycles moved on, and so the second NPR article did not get as widely published as the first one. I talked to Maggie Kisilowicz and Mike Hickey and asked them for their thoughts on Merrick's study, since they're two of our critical care specialists, and neither of them were aware of anyone who's using the vitamin C cocktail. Maggie asked some people in Toronto, and a couple of people, it sounds like, have tried it, but no one's consistently using it. For everyone that does want an RCT, though, there are some being planned. So according to Merrick, there's one starting sometime this May in Greece, as well as one planned for Australia and New Zealand, and another one in the US. Anyways, this showed up on my Instagram feed last week from someone I went to high school with. So vitamins are having a bit of a moment, and I hope that this talk has at least been a little bit interesting. To recap, we discussed some potential harms from vitamins like niacin and vitamins A, C, and D, as well as weight loss supplements in particular like Garcinia cambogia. And so the big take-home point is that hepatotoxicity is a rare side effect, but patients can require liver transplants, and there are some fatal cases as well. And just a reminder that with herbal supplements in particular, there can be drug interactions that can lead to conditions like serotonin syndrome or mania, particularly for patients that have a previous psychiatric history. Vitamin D is having a bit of a moment in research for a number of painful conditions, and it may be beneficial for painful diabetic neuropathy, chronic pain, and dysmenorrhea, but the jury is currently still out. And then finally, Paul Merrick's cocktail of vitamin C, thymine, and hydrocortisone does have some background evidence, and the results are intriguing, but consensus generally seems to be that most people won't be adopting this practice until there's an RCT. But there are also people who have decided to go ahead, and they're already treating patients with this. So also to be aware, there are anecdotal reports of families requesting vitamin C for their family members after seeing media reports. So I have a couple of thank yous. George was my supervisor, and his post about Merrick's study was the first time I had heard of it, and he encouraged me to pursue this topic. Lauren let me bounce ideas for Grand Round topics off of her, told me I wasn't crazy when I had the idea for this talk during the media frenzy around Merrick's findings, and then she also found some great gifts. Maggie and Mike provided their critical care perspectives on the study, and Isabel as well for being a great general cheerleader. So these are my references. Any questions?